So, nonetheless, we're going to talk today about polycythemia vera, and my goal in this talk is really to approach two questions. One is, how do we think about approaching polycythemia vera in 2025, but also how might we approach the treatment of polycythemia vera beyond 2025? And we'll kind of get into some recent data that I think is provocative in how we might think about this. So when we think about PV, right, the fundamental thing is that clinically PV is a disease of having too many red blood cells. Now there's a couple of caveats with that statement. One is that patients can have an increased platelet count and can have an increased white count with polycythemia vera. So these are not exclusive things, but really having an increased red count is the hallmark of the disease. The second thing is that with polycythemia, there are patients who actually initially, by the looks of their blood counts, don't appear to have an increased hematocrit or hemoglobin. And the hematocrit is the concentration of red blood cells. You saw the beautiful image from Dr. Nangalia earlier that shows, what happens with blood when it separates and the, cells precipitate. And if you think about hematocrit, that's kind of what we're thinking about is that concentration of red blood cells. Um, and there are patients who have what is termed masked polycythemia, and these are patients for who the red count and the hematocrit don't quite meet the textbook definition for having polycythemia. And the only way to really make a diagnosis in those patients is by doing a bone marrow. And there are many reasons why that can manifest. Sometimes it's just people are profoundly iron deficient at the time of their diagnosis. So doing a bone marrow in many cases, I think, is fundamental to establishing the diagnosis because there are patients for whom the platelets are really the thing that draws the attention to from their CBC and gets them referred to a hematologist, and their hematocrit may or may not be quite so elevated, or they're the thing that captures somebody's attention. But in some of those cases, you're actually dealing with PV and not ET. So I think a bone marrow is important, not in every circumstance, because there are circumstances where it is absolutely clear from the blood counts and other tests that somebody has PV, but in other cases this is not always obvious. Now, as we think about the approach to PV and how we think about treating it and how we think about risk stratification, everything really at the moment comes down to the risk of having a blood clot. And if you look here at this historical data, the risk of thrombosis is really, of all the risks and things that can happen with the disease, the major risk, right? The 15-year thrombosis risk, at least in this data set, was about 27%. Which is not to say that other things cannot happen. And this is where some of our thinking probably needs to evolve, because the disease can turn into other things. It can turn into myelofibrosis. It can turn into acute leukemia. Are these things common? No, they're not common. But, when we show a statistic like this and say, and give a 15-year risk and say, well, it's 6% or leukemia is 7%, I'm not sure that this is really all that meaningful. And that's really for two reasons. One is that if somebody is diagnosed earlier in life at age 25 or 30, and I have many patients who are under the age of 40, as do I'm sure my colleagues, how we think about risk needs to be different in that patient versus somebody who is, for example, diagnosed at the age of 70 or 75 years old, right? The risk will likely increase as time progresses. And so this number is static and potentially not that useful to think about this. The second thing is that this is what this starts to tell us is that we have to do a better job of trying to identify who are the patients at the greatest risk of their disease progressing. We have some early hints from genetics, but we really need to do a much better job at identifying early on our patients who are at the highest risk of their disease progressing, because it is not likely to be a factor for most patients, but for the patients who are on that pathway, I think we should start to think differently. So with that in mind, our goals in treating PV are really centered around reducing the risk of having a thrombotic event. And by thrombotic event, I mean things like heart attacks, like strokes, like deep vein thrombosis, but also there are sort of clotting events that can occur in PV and in ET patients that are not so common in the general population. And that can be things like blood clots in the abdomen or in the blood supply to the liver. In fact, having a JAK2 mutant disease is one of the more common reasons for somebody, for example, to have a blood clot in their liver or the circulation in their abdomen. Um, but the other thing that is important is that many PV patients are very symptomatic. And the classical things we think about are things like itching, but a number of other things can occur. And these can be things like night sweats. People can have unexpected weight loss. People can have abdominal pain. So there are a variety of symptoms that can occur, and it's important that we pay careful attention to these things. When I mentioned itching, I think it's always important that our patients hear affirmation from us that itching, when we say itching, it's not itching. It is a completely different and very difficult symptom for many patients, right? So this is something that we need to pay attention to, and obviously Dr. Mesa and colleagues have done the landmark work in trying to define the symptom burden and also to be able to sort of monitor it in a careful manner. All of we've talked about genetics here, and I'll get into this a little bit later. But one of the things with PV as opposed to ET and myelofibrosis is that PV is fundamentally really a disease of a JAK2 mutations. Almost 99% of patients have a JAK2 mutation, and that potentially gives us some different ways of thinking about this. And I'll get into that later in the talk. There are people with very rare mutations that cause PV that are not in JAK2, but the gene that typically where that occurs is actually a regulator of JAK2. So everything really is about JAK2 from a genetic perspective and in PV as we think about this from a diagnostic perspective, but potentially also a therapeutic perspective. So how do we treat PV? Well, we do things like therapeutic phlebotomies. We use cytoreductive agents, which you heard Dr. Bave define, right? These are drugs that lower blood counts. Hydroxyurea is the drug that we use most commonly in this disease, but interferon has played a large role, and we'll get into this. JAK inhibitors here, ruxolitinib is FDA approved for the treatment of PV in certain settings. And so this becomes an important discussion in terms of the things that we can do. And we'll talk about this in a few moments. And excuse me, then there are other things that we have to think about carefully. Aspirin. Aspirin is really fundamental to the treatment of PV. You heard the data with regards to ET that it's somewhat context dependent. With aspirin and PV, there's really strong data that aspirin is actually fundamentally important to the treatment of PV. And the other thing that I think is really, really important that we don't, I think, do a good enough job about talking about is lifestyle modification. When I think about PV and the risk factors involved in PV, it's important to realize that all of the other things that increase the risk of somebody having heart attack or stroke, which are clotting events, are important to address in somebody who has PV. And that includes things like, cholesterol, like blood sugar, like blood pressure, like being inactive. All of the things that put any person at risk of having cardiovascular disease, in my opinion, become much more important things to focus on when somebody has PV. And these are things that you can intervene on. These are things you can modify in many cases, not just with pharmacologic agents, but with lifestyle modifications, right? This is an important part of the conversation when we talk about how to manage PV. We mustn't overlook the simple and basic parts of reducing people's risk of clotting. So based on this, right, how we approach the treatment and the management of PV is really defined by what do we think somebody's risk of having a clot is, right? We don't make our treatment decisions based on what we think somebody's risk of progressing is, but it's about what we think their risk of having a clot is. And we essentially put people into two categories. If somebody is under the age of 60 and has never had a clotting event, we call them low risk. And keep in mind, this is a relative term, low risk and high risk. This is not no risk and some risk. Um, and in people who are either over the age of 60 or who ever had a thrombotic event, they go into the high risk category. So for patients who are in the high risk category, the recommendation for treatment is to put a patient on a cytoreductive therapy. And the cytoreductive therapies, as I've sort of defined, are listed here, and that can include interferons, which could be Pegasus, that could also be Bezremi or Ropeg interferon, which is FDA approved for the treatment of polycythemia vera. That could include hydroxyurea, and in some cases, those agents could include ruxolitinib. Um, when we think about patients in the low risk categories, we really manage patients currently with phlebotomy and aspirin. And as I'll get to kind of in the second half of the talk, I think we need to begin to rethink this a little bit, but at least that is the current standard of care. Um, and in patients who are having very frequent phlebotomies, what does that mean, very frequent? Well, in the beginning of somebody's therapeutic journey, it's not uncommon that they get phlebotomized every week or 2 weeks or every month as we try to get their iron stores depleted because iron is needed for hemoglobin and depleting the iron is the way of trying to decrease the red cell burden. But over time, once we're kind of, let's say, past the first 3 to 6 months of phlebotomizing somebody, if somebody is continuing to get frequent phlebotomies, this may not be necessarily a good thing for a number of different reasons. And that could prompt us to say, well, somebody's low risk, but I think we need to put them onto a therapy. So that's one way we put a low risk patient on therapy. And the second is that if somebody just has symptoms that are not well controlled, phlebotomy can help alleviate certain symptoms. It's not uncommon, for example, that a patient has headaches when their hematocrit gets too high. They get a phlebotomy, they feel better, right? But if the symptoms are persistent, which can be headaches, which can be burning or tingling on the fingers, or a number of other things that are not controlled by aspirin and phlebotomy, that's also a reason for us to think about putting a patient onto a cytoreductive agent. Now, as I mentioned a moment ago, aspirin is fundamental for the treatment of PV. And this is data from a randomized control trial. And what it is showing you is the probability of not having an event defined as a cardiovascular or clotting event over time. And you can see from the curves here that the patients were randomized to aspirin or to placebo. And the patients who got aspirin had a higher likelihood of not having an event occur versus those who got placebo. And this was a statistically significant difference. And this data has really been the foundation of our use of aspirin in polycythemia and has told us that it does improve the likelihood of a patient avoiding an event like a thrombotic event. Now, if a little bit of aspirin is good, excuse me, is more aspirin better? This is a reasonable question, and the answer is no. It seems that in the US, the low dose aspirin or the baby aspirin is 81 milligrams daily, and in Europe it's 100 milligrams. But those doses are really enough to attenuate the risk of having a clotting event. Using more aspirin, particularly a full dose aspirin, which is 325 milligrams, doesn't actually help reduce the risk of clotting, but it does increase the risk of bleeding. So there is a fine line in terms of the doses of aspirin that one wants to use in polycythemia vera. Dr. Bave mentioned an important thing, which is that sometimes, when patients are having symptoms such as burning or tingling in their fingers, you can actually give aspirin twice a day. You can give 81 milligrams twice daily, which is a total of 162 milligrams, and that dose is safe and fine. It does not increase the risk of bleeding. Going above that seems to, but that is a safe thing to do and sometimes can be very helpful in terms of reducing symptoms from PV. So, what are we trying to achieve from a numbers perspective? Well, we tried to keep the hematocrit in patients less than 45%. That is our major therapeutic benchmark in polycythemia vera. How did that come to be? Well, there was a trial that was done now a number of years ago that randomized patients to their hematocrit being 45 to 50% or less than 45%. And the study looked at clotting events and cardiovascular events. And maybe I'll draw your attention to the cardiovascular events curve here. And what the graph is showing you is that the patients who were kept in the low hematocrit strategy, this is less than 45%, versus those who were allowed to keep their hematocrit from 45 to 50%, had a lower likelihood of an event occurring. So these curves are showing you essentially what is the probability of remaining event-free, or the probability of nothing happening. And you see that the curves are clearly different, and that those patients here who were in the low hematocrit strategy are the ones who did better over time. So as a result of this data, the hematocrit threshold of 45% has become the standard of care. So we want to keep the hematocrit less than 45%. This is a very clear thing, and this is, this is absolutely the treatment recommendation. However, it is important to think about that's kind of the line in the sand, right? We don't want to go above that on a consistent basis, but is there a lower number, right? Well, how low can it be? How low should it be? And this is where I think things are a little bit of a gray area. There is data to support the idea that perhaps female patients should have a hematocrit that's lower, perhaps less than 42%, although that data is not randomized data to the level that this is. But sometimes it's actually symptom driven. It isn't uncommon that a patient has a good sense of where their hematocrit needs to be for them to be asymptomatic. I've certainly seen patients who, they need to be under 43% because once they hit 43%, the terrible headaches come back, right? So I think 45 is the line in the sand, but a lower number may be a reasonable thing for certain patients in certain contexts, particularly if a certain number is associated with the onset of symptoms. We always have to be careful, of course, when we think about lowering the threshold, because we are making patients iron deficient by phlebotomy. Now, is that a bad thing? Well, iron deficiency can cause symptoms, right? It can cause restless leg syndrome. It can cause other symptoms that can be very troublesome. There is some thought that, lots of phlebotomies may increase the risk of certain types of cardiovascular disease. So phlebotomy and making people iron deficient is not a benign thing necessarily. And so using it and being somewhat judicious at, what level we phlebotomize somebody is an important consideration. Now, aside from phlebotomy and aspirin, what about the cytoreductive agents? So I think, hydroxyurea is the drug that is used most commonly in the United States to achieve the goal of cytoreduction. And, what is one of the benefit of that beyond a phlebotomy? There's a couple of different studies, but one that I'll point out is this one on the third line down, the PVE cohort of the ECLAP study, which was a study which essentially looked at the outcomes of patients treated with hydroxyurea versus those who were just managed with phlebotomy, and asked the question, are there more clotting cardiovascular events that occur in people who got hydroxyurea versus those who got phlebotomy? And the answer from this data, at least, was that it seemed that there were less events that occurred in patients who got hydroxyurea as a treatment versus those who got phlebotomy. And there's a couple of reasons that one can think about this and why this difference could exist. One is that we do fool ourselves a little bit with blood counts, right? If somebody gets their blood count every 3 months, and every 3 months their hematocrit is over 45, and we phlebotomize them, was their hematocrit only elevated on the day that they came in for their blood count? Absolutely not. Of course, they probably had an elevated hematocrit for weeks prior to their blood draw. And so there's this bit of artificial thinking in how we think about when somebody's at risk. If we really believe somebody's at risk for when their hematocrit is over 45%, it might make sense that we try to keep it under 45 for as long as possible. But if we're only checking the blood every 3 months, do we really know what it's like in between? No, not necessarily, right? The second is that other blood counts do play a factor in the risk of blood clots. in patients with polycythemia, namely the white blood count. There are a number of studies, not every study agrees with that, but most studies do seem to suggest that the white blood count associates with the risk of clotting in PV. Do we have an abundance of data that lowering the white count will reduce that risk? We don't. There is some data to support that idea, but that has been something that we haven't necessarily addressed in a robust manner. And so something like hydroxyurea, which can lower all of the blood counts, including the white count, can that make a difference in reducing this risk? The answer is potentially yes. So there's a couple of reasons why cytoreductive therapy, and in this case, particularly hydroxyurea, may have a beneficial role in reducing the risk of having a clot. Uh, Other drugs, let's talk about interferon now, right? So Dr. Bave has kind of given you a bit of an outline of interferon. Interferon has been used now for many years in treating MPNs in general, but there's a long experience with polycythemia vera. And there have been a number of studies, and I don't want you to get bogged down with details from any of these slides, but I just want to kind of illustrate some larger points, which is that a number of studies have clearly shown that patients who are on interferons, and these are pegylated interferons, have achieve response in terms of what's called complete hematologic response. And what that means is that all of the blood counts essentially normalize, right? We're not talking about remission. We're not talking about looking at the bone marrow. We're talking about, do the blood counts normalize? And again, the principle being that if we normalize the hematocrit and we normalize the white count, then we should reduce the risk of having a clotting event. And so all of these studies collectively have shown us that interferon can absolutely achieve this normalization of blood counts. Okay, that is an important thing. What these data have also taught us is that interferon takes time to work. It is not something that works quickly. Hydroxyurea can work very quickly. We can get somebody's counts under control, excuse me, in a matter of weeks. Interferon may take months to get the counts under proper control. So that's one consideration we have to think about. The second thing is that, the side effects from interferon are different from the side effects that we see with hydroxyurea. We see a number of different side effects that can occur with interferons, and that includes dysfunction of the thyroid, dysfunction of the liver, itching can occur, depression has been reported as well. The latter side effects, these are not frequent things, but they are things we need to think about carefully in patients. And the abnormalities of the thyroid and liver often will improve over time. But when we selected treatment with our patients to treat their any disease, we always have to think about what other things are going on, right? Do they have other medical conditions or other considerations in terms of trying to choose the optimal treatment? Now, this study was already mentioned, the MPD-112 study, and this study was a very important and interesting study because it was a randomized trial for both ET and PV patients that asked the question, is there a difference in outcomes in treating patients with hydroxyurea or pegylated interferon or Pegasus? And what was one of the important things about this study is that not only did it look at changes in the blood counts, it also looked at the bone marrows. These patients who were on this trial did undergo bone marrow biopsies. So we had I think, a more robust picture about what the overall effect was of this intervention. And as was mentioned early on, right, in the initial 12 months, there didn't really seem to be a response difference, right? The proportional response in people with PV was essentially the same statistically in the patients who got the Ropeg interferon, sorry, not Ropeg, the Pegasus versus those who got hydroxyurea. Over time, these numbers did change a bit. Again, coming back to the principle that interferon takes time to work, all right? And at least at 12 months, the bone marrow changes were really not quite so different. Side effects wise, we did see, as we would expect, more often depression with interferon and flu-like symptoms versus what we saw with hydroxyurea. And this is just showing again at 12 months what the difference in the hematocrit control, which numerically was better with pegylated interferon. But again, statistically, at 1 year, it wasn't that different, with some changes noted over time as time went on. But that lays the foundation, at least for how we think about the next study that I'm showing you here, which is the study of Ropeg interferon in polycythemia vera. Ropeg interferon is the other name for it is Bezremi, and I'm sure there's a few patients who are on this drug in the symposium today. But this study was interesting in that it took patients who had had very limited prior treatment, and these are all PV patients, and randomized patients to get Ropeg interferon or to get hydroxyurea, and they did an initial readout at 12 months. But they then followed the patients up for 3 to 5 years. And this is the important thing because, again, I come back to the principle interferon takes time to work. So, what does this data tell us? Well, let's look at these curves and let's say, we'll look at up to here. So let's just look at the first parts of the curve. And what this curve is showing you is the proportion of people who have a response. Now, the response here is the complete hematologic response. This is not a bone marrow response. This is not asking a question about remission. This is asking, are the blood counts normalized? And the two arms are the hydroxyurea arm, which is in this grayish color, and the Ropeg interferon arm is in the red color. And so if you look initially at the response rates, right, it is clear that the hydroxyurea arm is actually doing better. You have a higher response rate than you do with Ropeg interferon. And this is in the first couple of months of the study. As you see down here, this is months on the study. Is this surprising? No, because again, hydroxyurea has a quick onset of action or quicker onset of action versus what you see with Ropeg interferon. But curiously, as time went on, the curves invert, and you see that here. And the response rate with interferon, with the Ropeg interferon, is actually better than it is with hydroxyurea over time. There's a statistical difference that emerges over time. So time is a key variable, in my opinion, in this data set. And overall, this continued to be the case with extended follow-up of patients. And this is really what has led us to say that, in patients over time, Ropeg interferon seems to be superior to hydroxyurea in achieving the complete hematologic response as the endpoint. But again, time is the key message here. In terms of side effects, we always have to think about side effects. The side effects that were observed were changes in liver function, which again are largely reversible if you stop the drug or lower the dose of the drug. But other than that, there were no major significant differences in the side effects of the treatment. So, uh, pausing here before we step into the next part of this, there's a couple of things to surmise, right? One is, does does hydroxyurea work? Yes, it can control the blood counts. Do interferons work? Yes, they can control the blood counts. Is there data to tell us that one is better than the other? Yes, if the question is, are we controlling the blood counts? The Ropeg interferon data shows us that it is better than hydroxyurea at controlling the blood counts in a head-to-head trial. Should everybody therefore be on Ropeg interferon? Again, we have to come back to the side effects of each drug and whether or not they are appropriate given a patient's individual other ongoing medical issues and as well as other considerations. I would say to you the message is, look, these are all drugs that can work and that are effective in achieving the goals of controlling the blood counts. And again, there is data to support the Ropeg interferon doing a better job of that in patients. But one caution with any type of clinical trial data is that there is often a gap between the patients who are enrolled in a clinical trial and the patients that we see in everyday practice. When somebody enrolls in a clinical trial, they have to meet certain criteria to get into the trial, right? We're selecting for a somewhat more healthier population that may not have as many ongoing medical issues as we see in everybody else who walks in the door. So we always want to be somewhat cautious in how we generalize data from a clinical trial that applies to select populations to everybody who walks in the door. Nonetheless, these are useful agents. Now, that brings us next to ruxolitinib, and the basis for studying ruxolitinib in PV is on a sort of pharmacologic level, very basic, right? Which is that this is a disease of JAK2 mutated JAK2 mutations, and so inhibiting the JAK2 signaling pathway, which is what Jakafi does, or ruxolitinib interrupts this pathway, is a logical and reasonable thing. How this was studied in actual clinical trials was that patients who met this definition of resistance or intolerance were the patients who were studied. So what does this mean? These were patients who were on hydroxyurea and developed intolerance, which is, I think, an easier concept to understand, meaning that patients were having side effects that were not acceptable on Hydrea. And that includes having things like skin ulcers, like skin cancers, like fevers, which sometimes occurs with hydroxyurea, or with gastrointestinal toxicity. So these are what we would term intolerance to hydroxyurea. But there's also a definition of resistance, and resistance essentially means that you're using Hydrea at a dose that is not achieving control of the blood counts, or you're having to use such a high dose of the hydroxyurea that it is causing the other blood counts to go really down below where we want them to be. People's, for example, white count gets too low or their platelets get too low. This is a definition of resistance. And this is a real thing. I would say it affects about 20% of patients who are on hydroxyurea. So if we think about patients like that who meet these definitions, what happens if we switch their therapy to a JAK inhibitor, to ruxolitinib? And so this was the response trial. This was a trial for patients who met the definition of resistance or intolerance, but also had an enlarged spleen, which is not uncommon in PV. And they were randomized to get hydroxyurea, most commonly as a standard therapy, or to get ruxolitinib slash Jakafi, the JAK inhibitor. And the outcome here was, is the hematocrit controlled and does the spleen shrink? And as it turns out, and maybe let's first focus here on the hematocrit control, right? 60% of patients who got the Jakafi or ruxolitinib had achieved control, excuse me, of their hematocrit versus only 20% of patients who continued on hydroxyurea. And in terms of reducing the size of the spleen, this was clearly superior in the patients who got the Jakafi versus those who got hydroxyurea. So this trial, met its endpoint, right? You get better control in patients who meet this definition of resistance or intolerance to hydroxyurea in control of their hematocrits. What about symptom control? So this was really interesting, right? In that if we look at symptoms in aggregate, using the MPN symptom assessment form, this was, of course, developed by Dr. Mesa and colleagues, we see that a much higher proportion of patients achieve an improvement in their symptoms treated with ruxolitinib versus those who were continued to be treated with hydroxyurea. This is important. I think that amongst the drugs that we have to treat symptoms, at least in polycythemia, ruxolitinib is among the best drugs that we have. And this is particularly true for things like itching. Again, coming back to the idea that itching in PV is not itching that you have from dry skin. This is a very different thing, as patients have explained to me a number of times, but this is amongst the best drugs that we have to control and deal with this, as well as a number of other symptoms. So this is a good drug for, controlling the hematocrit, but also for controlling symptoms. And of course, if a treatment is to be something that we utilize, it has to have a durability of response, right? It's not enough that a treatment just simply, has an effect. It has to have a durable effect. And in fact, the data shows us that overall, most patients continue to maintain a response to therapy. This is showing you the proportion of patients who continue to respond. Does it decrease over time? It does. But still, the majority of patients continue to stay on ruxolitinib and continue to benefit from it. So this is a really powerful tool in our armamentarium to deal with polycythemia vera. So, the way we currently think about this is aspirin and phlebotomy for our quote unquote low risk patients, and for high risk patients, ropeg interferon or Hydrea are appropriate treatments. And for patients who have been on Hydrea but are resistant or intolerant or having refractory symptoms, ruxolitinib is FDA approved. You could also switch to one of the other agents. There are newer agents emerging, including a drug called rusfertide, which Dr. Kremenskaya will talk extensively about. So that is how we think about, our higher risk. Can you give, if the data is true, right, that I showed you that Ropeg does a better job of controlling counts than Hydrea, but we also know that Hydrea seems to have somewhat of a better effect than phlebotomy in higher risk patients. Is the same thing true in low risk patients, i.e., the younger patients who have not had a clotting event? And this was studied in this study that's shown here, whereby younger patients, age 18 to 60, were randomized to continue the usual aspirin and phlebotomy or to switch to the Ropeg interferon. And what the data shows here, and let's just maybe focus on hematocrit control, is that significantly higher proportion of patients were able to have control of their hematocrit amongst those who got Ropeg interferon versus those who were treated with hydroxyurea. So this is parallels what we saw in the higher risk patients. But importantly, disease progression was more frequent in patients who got hydroxyurea versus, sorry, not hydroxyurea, phlebotomy and aspirin versus those who got Ropeg interferon. The same thing is true here. These are patients who got phlebotomy and aspirin, not Ropeg interferon. So disease progression here, we have to be a little bit cautious about the definition because it did include the definition of the platelets getting higher, which I think is debatable as whether or not that really means disease progression. But nonetheless, this signal actually caused the study to be put on pause and no further patients were able to be accrued. But we do have this data that is saying to us, well, in younger patients, there may be a benefit to putting patients on cytoreductive therapy, namely Besremi. And in terms of maintaining a response, this was also true, right? We want to see durability. And even if you look 2 years out, a higher proportion of patients who got Ropeg interferon were able to maintain their response versus those who were on aspirin phlebotomy. So all of this leads to the sort of the last part of this discussion, which is how do we think about this going forward, right? Are we, and I want to frame this in the context of allele burden. You've heard this mentioned a number of times, and so I don't need to get into the definition. When we talk about allele burden, JAK2 allele burden or variant allele fraction, as Dr. Nangalia and Dr. Baves have already kind of defined, let's just make this a very simple definition. We're just talking about the amount of the JAK2 mutation in the blood or bone marrow. We've been talking about normalizing the blood counts, right? We want to keep the hematocrit under control. But if this is a marker of the disease, can we think about targeting that instead? And what's the evidence for that? This requires that we kind of think about our thinking. We rethink our thinking in this disease. Phlebotomy isn't a new thing, right? Phlebotomy has essentially existed since 1000 BC. It was originally developed in Egypt as a way to treat a number of different things, and this has been true for the last several hundreds of years, where bloodletting was used to treat numerous conditions. You see a painting here from the 18th century depicting a surgeon performing a bloodletting, right? So one way to think about it is if we're still using it, that means it's tried and true. And the other way to think about it is, why are we still using a modality from 1000 BC? This is a fair question. But if we want to refocus, we have to ask the question, what are we going to refocus on? So let me make an argument to you about JAK2 allele burden. Does it clinically matter, right? Dr. Nangalia made the statement, we think about this as a number, and it reflects how much of this is in these cells in the blood, right? And the question has to be, well, does that number really reflect anything, or is it just a number? What we do know is that the JAK2 allele fraction, again, the amount of JAK2 in the blood, correlates with an increased white blood count. It correlates with an increased risk of thrombotic events occurring in the venous circulation. It correlates with an increased risk of the spleen getting bigger, and it does actually correlate with an increased risk of progression to myelofibrosis. So this is at least important data that says to us, look, the number actually ties into clinically how patients do and how they feel. So that's the first argument that says, well, maybe we should be looking at this. The second thing is that the question then becomes fine. If you argue that the amount of the JAK2 mutation matters, does changing it matter? And can you change it? Well, you can change it, right? Interferon has a long track record of being able to reduce the JAK2 allele burden in a relative manner, right? And you see these are percentages. So if you look at treatment on patients over time, you see, for example, in this cohort, it went from a median of 64 down to 4.5, right? So do we have drugs that can reduce the JAK2 allele burden? Yes, yes, we do. And they take time. That again is the other thing here. It takes time for this to occur. And if I go back to the Ropeg interferon study, what you see is the same thing, which is that the patients who were excuse me, treated with ropeg interferon had a marked reduction in their allele burden over time versus those who were on the hydroxyurea, where it actually went up over time, right? So not only did the blood counts get better with the ropeg interferon, but molecularly, right, the amount of JAK2 mutation goes down. And that correlates potentially with an important finding, which is that, if you look 6 years out for patients who were treated with ropeg interferon in this trial, their likelihood of having an event means a clotting event or progression to myelofibrosis or death or acute leukemia, is actually significantly lower than the patients treated with hydroxyurea in this study. That's an important finding, right? Because it's not about making the numbers look good. It is about what actually happens to patients. What is the patient's journey? What are the patient's symptoms? Similarly, if we think about the randomized studies of interferon that were presented, Dr. Bave showed this slide. Same thing is true with Pegasus, right? With Pegasus over time, once you get past 12 months, the JAK2 allele burden actually starts to go up in patients who get hydroxyurea and goes down in those who get Pegasus. This is an important finding. And, the more pieces of data that are kind of aligning and telling us the same thing, the more confidence that we have in the message. What about ruxolitinib, the JAK inhibitor? Same thing is true here, that over time and with treatment, let's pay attention maybe to the green line here. You see that the JAK2 allele burden actually does steadily decrease over time. Does this matter? That's the next question. We've said JAK2 allele burden correlates with certain features of disease. We have drugs that can reduce the JAK2 allele burden. So then the next question is, does this actually make a difference? And there are a couple of pieces of data that support this. One is that the spleen reduction that was observed in the response trial, remember that was the trial of patients being randomized to ruxolitinib or to staying on hydroxyurea. Spleen reduction was far more likely in patients who had a reduction in their JAK2 allele burden. So that's one thing that says to us, okay, reducing the number correlates with actual clinical changes that we care about. And with regards to treating with Pegasus, the same thing is true, that if we look at the change in the JAK2 allele burden and we look at the patients who achieve a complete remission versus a no response in red, or a partial response, the more likely you are to have a reduction in the JAK2 allele burden correlates with the likelihood of having a real clinical response to the therapy. This is another piece of data that ties these two things together and says reducing this does correlate with outcomes, right? And one other important piece of data from this was that patients were more likely to have a reduction in a response if we started where their JAK2 allele was lower, which again makes the argument that maybe starting people on therapies earlier, rather than waiting for the disease to progress, might make sense. This is just a suggestion from the data, but we need to think about it further. And the last piece of data I think is very important, and this is a really important trial. This was another trial that took patients with PV who were resistant or intolerant to Hydrea and randomized them to get ruxolitinib or best available therapy. But this study looked at what happens longer term. What is the event-free survival? Again, events are things like clotting events, like transformation to myelofibrosis, like transformation to leukemia. Do you affect those things? And the answer is, in patients treated with ruxolitinib versus those who continued on mostly hydroxyurea, there was a statistical difference in favor of patients treated with ruxolitinib, that they were less likely to have an event occur, and the events are described here, right? All of the things that we care about in terms of patient outcomes if they were treated with ruxolitinib. But more importantly, or not more importantly, but interestingly, I would say, if we look over here in panel C, the patients who met the definition for having a reduction in their JAK2 allele burden were more likely to have this event-free benefit than patients who did not. This again ties together the concept that reducing the JAK2 allele burden actually correlates with things that are clinically important in terms of patients not having progressive events or clotting events. So as I wrap up, I think, a couple of key points to make, right? There are a lot of open questions here, right? And we are in a position where it is, I think, time to challenge how we think about PV treatment and management. We have more agents that are more effective than we've had. There are more drugs coming that target JAK2 that potentially may be even more impactful than the drugs we have now. But that still means that we have to, answer these questions. We have to answer the question about whether everybody should really be on a cytoreductive therapy from the onset of their disease, the principle being if you can drive the JAK2 mutation down earlier, might patients have a better long-term outcome? Um, does this, and if that is true, does that mean that longer term patients do better? We need to know more about that. Um, how much reduction do you really need? Does it really matter? Do you need to have it undetectable, which would be ideal, or does it just need to get to a certain level? We don't know the answer to that. At the end of the day, we need to do more work here, but we're in a good position to ask these questions and potentially change the intervention. And ultimately, we need to change the outcome. For anybody who's interested and wants to do more reading on this topic, this is an article that a number of us, Dr. Pemaraju, Dr. Mascarenhas, and I, and others, wrote and published in Blood. This is the link to the article, which should be available for free download. If you are not able to download this and you're interested in this article, please just email me. I absolutely believe that everybody should have free access to published information. So if you are unable to access this and you want to get the article, I'll be happy to provide it with you. So with that, I will wrap up and turn things back over to Dr. Mace.